What if one overlooked detail before surgery led to a preventable complication, delayed the procedure, or even appeared on your CNOR exam? Many perioperative nurses focus on what happens inside the operating room, but the truth is that success often begins long before the first incision. In this lesson, you'll discover how a thorough preoperative patient assessment helps identify hidden risks, improves patient safety, and creates an effective care plan for every surgical procedure. These are the same concepts that experienced perioperative nurses rely on every day and the topics that frequently appear on the CNOR certification exam. Watch until the end to build a solid foundation for the rest of this course, and don't forget to download your free CNOR study guide, packed with high-yield exam tips and the most important practice questions, using the link in the description. Now, let's begin with the essential principles of preoperative patient assessment and care planning. The preoperative assessment begins the moment the patient is scheduled for surgery and continues until they are transferred to the surgical suite. Your primary goal during this phase is to gather comprehensive information about the patient's physical and emotional health status. This information forms the baseline data that you and the entire surgical team will use to monitor the patient throughout their entire perioperative journey. By collecting accurate details early, you can anticipate needs and prevent complications before they even happen. One of the first things you will do is review the patient's medical history, including past surgeries and any chronic conditions. It is vital to look for conditions like diabetes, cardiovascular disease, or respiratory issues because these can significantly affect how a patient responds to anesthesia and the stress of surgery. If a patient has a history of sleep apnea, for example, the anesthesia provider needs to know this to plan for safe airway management. Gathering this history is like putting together the pieces of a puzzle to see the full clinical picture. Next, you must carefully review the patient's current medications, including prescription drugs, over-the-counter medicines, and herbal supplements. Many patients do not realize that common natural supplements like garlic, ginseng, or ginkgo biloba can actually increase the risk of bleeding during surgery. On the exam, you will often see questions about which medications must be stopped before surgery and which should be continued. Your thorough medication reconciliation ensures that the surgical team is not caught off guard by unexpected drug interactions. Identifying allergies is another absolute priority during your preoperative interview. You need to ask specifically about allergies to medications, food, and environmental triggers like latex. A known allergy to bananas, avocados, or kiwi is a major red flag, because it strongly indicates a potential latex allergy due to biological cross-reactivity. Documenting these allergies clearly and ensuring the patient wears a designated allergy alert bracelet is a critical safety step you must know for the CNOR exam. Beyond the physical chart review, you must conduct a focused physical assessment of the patient. This includes checking vital signs, listening to heart and lung sounds, and assessing the condition of their skin. Noting the baseline skin integrity is especially important because it helps you distinguish between existing bruises or sores and new injuries that might occur due to surgical positioning later on. A thorough physical exam gives you real-time data about the patient's current physical stability. As a perioperative nurse, you must also evaluate the patient's psychosocial status. Surgery is an incredibly stressful event, and patients often experience high levels of anxiety, fear, or confusion. By assessing their emotional state, you can provide the right level of emotional support and communicate effectively with them. Calmly addressing their fears not only builds trust, but it actually helps lower their heart rate and blood pressure before anesthesia induction. Evaluating the patient's understanding of the planned surgical procedure is a key part of your nursing assessment. You must ensure that the patient knows exactly what is going to happen, why it is happening, and what to expect during recovery. If a patient seems confused about which body part is being operated on, you must stop and seek clarification from the surgeon immediately. This responsibility leads directly into the critical legal concept of informed consent. Informed consent is a legal and ethical requirement that must be met before any surgical procedure begins. It is always the surgeon's responsibility to explain the risks, benefits, and alternatives of the surgery to the patient. Your role as the perioperative nurse is to verify that the consent form is signed, dated, and appropriately witnessed in the patient chart. You also serve as a patient advocate, making sure the patient truly understands the information before they sign the document. If the patient asks you specific medical questions about the surgical risks or alternative treatments, you cannot answer them yourself. Instead, you must contact the surgeon and ask them to come speak with the patient again to clarify. The exam will heavily test your understanding of this boundary, because nurses advocate and witness, but only the performing provider can obtain the actual informed consent. Always remember that the patient has the strict legal right to withdraw their consent at any time before the surgery starts. Patient education is another major responsibility during the preoperative phase. You should use this time to teach the patient about postoperative expectations, like deep breathing exercises, pain management plans, and the importance of early mobility. Educating the patient before they are under the influence of relaxing anesthesia medications ensures they are alert and capable of understanding the instructions. This proactive teaching greatly improves their recovery process and reduces the risk of postoperative complications. Let us talk about fasting guidelines, which are often referred to as NPO status in the medical field. NPO stands for nothing by mouth, and these guidelines exist to prevent pulmonary aspiration, which is when stomach contents accidentally enter the lungs during anesthesia. The exam will expect you to know the standard fasting times, such as stopping clear liquids 2 hours before surgery and stopping a light meal 6 hours prior. Verifying the exact time the patient last ate or drank is a non-negotiable safety checkpoint. After gathering all this assessment data, you will use it to formulate specific nursing diagnoses. A nursing diagnosis is a clinical judgment about how the patient is responding to the surgical experience. For example, if a patient is visibly trembling and asking repetitive questions, a highly appropriate nursing diagnosis would be anxiety related to the upcoming surgical procedure. These diagnoses help organize your professional thoughts and drive the specific interventions you will choose. Once you have your nursing diagnoses, you will move into the care planning phase. Care planning involves setting measurable, achievable goals for the patient to reach by the end of their perioperative experience. An example of a good goal is stating that the patient will maintain skin integrity without any signs of redness or pressure injury during the surgery. The CNOR exam emphasizes that the care plan must always be individualized to the specific physical and emotional needs of each patient. With your goals established, you will then select the appropriate nursing interventions to help the patient achieve them. If your goal is to prevent infection, your interventions might include administering prophylactic antibiotics exactly on time and ensuring the surgical site is properly prepped. Every action you take in the operating room should tie directly back to the goals outlined in your preoperative care plan. This structured approach ensures nothing is missed during the fast-paced surgical environment. Special patient populations require you to adjust your standard assessment and care planning approach. Pediatric patients, for instance, need developmentally appropriate communication and often benefit from having their parents present during the start of anesthesia to reduce separation anxiety. Geriatric patients might have thinner skin, decreased joint mobility, and a higher sensitivity to medications, which means you must handle them with extra care. You must adapt your nursing care to fit the unique physiological age of the patient in front of you. You must also be keenly aware of cultural and religious beliefs that can deeply impact the surgical care plan. Some patients may refuse life-saving blood transfusions due to religious convictions, while others might request to keep a specific cultural or spiritual item with them until the last possible moment. Respecting and accommodating these beliefs whenever safely possible is a fundamental part of providing patient-centered care. The certification exam will test your ability to balance these patient preferences with strict operating room safety protocols. The final piece of preoperative preparation involves physically preparing the patient for the operating room. This includes ensuring they are wearing the proper hospital gown, removing all jewelry, securing personal belongings, and verifying that preoperative medications have been given. You will also make sure that the surgical site has been correctly marked by the surgeon while the patient is still awake. Site marking is a crucial step to prevent wrong site surgery and is a major focus of national patient safety goals. As you prepare to transition the patient to the surgical suite, you will conduct a final review of the patient chart. You are checking to ensure the history and physical is updated, lab results are present, blood products are available if ordered, and the consent is perfectly completed. This final chart check is your last line of defense to catch any missing information before the surgery begins. A thorough preoperative assessment guarantees that the entire surgical team is stepping into the operating room fully informed and prepared. Congratulations on completing this first section on preoperative patient assessment and care planning. I highly encourage you to complete the attached practice test right now while the information is fresh in your mind. Practice questions are proven to improve your memory retention and build your exam readiness by forcing you to apply what you just learned. The practice test is included with this lesson, so please take advantage of it to support your active learning journey. Next, we will move into the operating room to discuss intraoperative patient safety and positioning, so keep up the great work and I will see you in the next section. Welcome to Section 2 of the CNOR exam preparation course, where we will explore intraoperative patient safety and positioning. In this lesson, you will learn the critical safety protocols used inside the operating room to protect patients while they are most vulnerable under anesthesia. Understanding these concepts is vital because proper positioning and strict safety checks prevent devastating injuries like nerve damage or wrong site surgeries. Get ready to master the hands-on skills and safety measures that are tested heavily on the certification exam. Let us dive in and continue building your perioperative expertise. Transferring the patient from the stretcher to the surgical bed is our first major safety checkpoint inside the operating room. You must always lock the wheels of both the stretcher and the surgical bed before any movement begins to prevent accidental falls. It takes a coordinated team approach, usually requiring at least 4 staff members for an adult, to ensure the patient's spine remains straight and their limbs are protected. Safe transferring is not just about patient safety, it also protects you and your colleagues from serious back injuries. Once the patient is safely on the bed and before any incision is made, the entire surgical team must perform a universal protocol known as the surgical timeout. During the timeout, all activity in the room stops, and every team member pays active attention. Together, you will verbally verify the correct patient identity, the correct surgical procedure, and the correct surgical site. The exam will test your understanding that any team member can and should speak up if something seems wrong during this critical pause. Surgical positioning has 2 main goals, which are providing the surgeon with optimal access to the surgical site and keeping the patient completely safe from harm. Because anesthesia blocks the patient's normal pain receptors, they cannot tell you if a position is causing them discomfort or stretching a nerve. This means the perioperative nurse must act as the patient's protector and meticulously assess their body alignment. You must use padded positioning devices to support the patient's natural anatomy and relieve pressure on bony areas. The most common surgical position you will encounter is the supine position, where the patient lies flat on their back. While it seems simple, lying flat on a hard surgical table for hours can cause significant pressure on the back of the head, the tailbone, and the heels. You must place soft positioning aids, like gel pads or foam heel protectors, under these vulnerable areas to prevent skin breakdown. You also need to ensure the patient's arms are either tucked securely at their sides or extended on arm boards at an angle less than 90 degrees. Keeping the arms at an angle less than 90 degrees when using arm boards is a strict rule designed to protect the brachial plexus. The brachial plexus is a major network of nerves that runs from the neck down into the shoulder and arm. If the arm is stretched too far backward or outward, these delicate nerves can be permanently stretched or torn, leading to chronic pain or loss of arm function. Questions about preventing brachial plexus injury appear frequently on the exam, so remember that 90-degree limit. The prone position, where the patient lies flat on their stomach, is often used for surgeries on the back or spine. Turning a patient from their back to their stomach while they are asleep requires intense coordination and careful protection of their airway. Once prone, you must ensure the patient's chest can fully expand for breathing by placing special padded rolls under their torso. You must also check that their eyes are taped shut and free from any pressure to prevent devastating postoperative vision loss. Another heavily tested position is the lithotomy position, which involves placing the patient's legs up into elevated stirrups, often used for gynecological or urological procedures. The most important safety rule here is that both legs must be raised and lowered slowly and simultaneously by 2 staff members. Moving the legs together prevents dangerous shifts in blood pressure and protects the lower back from sudden twisting injuries. You must also ensure the stirrups are heavily padded to protect the nerves that run along the outside of the knee. The specific nerve you are protecting when padding the outside of the knee in the lithotomy position is called the common peroneal nerve. If this nerve is compressed against the hard metal of a stirrup, the patient can wake up with a condition called foot drop, where they are unable to lift the front part of their foot. This is a classic exam topic that perfectly links a specific surgical position to a specific potential nerve injury. Proper padding and careful leg placement are your primary defenses against this complication. When a patient is placed in the lateral position, they are lying completely on their side, which is common for chest or kidney surgeries. In this position, the patient's body weight is heavily concentrated on their lower shoulder and hip, creating a high risk for pressure ulcers. You must place a small pillow or specialized roll just under the lower armpit, called an axillary roll, to protect the nerves and blood vessels in the shoulder area. Careful attention to spinal alignment is also crucial to prevent neck and back strain. Sometimes the surgeon will request the Trendelenburg position, where the entire surgical bed is tilted so the patient's head is lower than their feet. This position uses gravity to pull the abdominal organs upward, giving the surgeon a better view of the lower pelvis. However, tilting the patient head downward pushes all those organs against the diaphragm, making it much harder for their lungs to expand. Because of this respiratory compromise, patients should remain in Trendelenburg for the shortest amount of time safely possible. As you move and position patients, you must actively prevent 2 physical forces called shearing and friction, which can easily damage the skin. Friction happens when the skin rubs directly against the bedsheets, like a painful carpet burn. Shearing is more internal, occurring when the skin stays in place but the underlying bone and muscles slide, tearing delicate blood vessels underneath. To prevent these injuries, you should always use a friction-reducing transfer device or a lift sheet to move the patient, rather than dragging him across the bed. Preventing retained surgical items, which means leaving a sponge or instrument inside the patient, is one of your most critical responsibilities. To prevent this, you and the surgical technologist will perform strict, audible counts of all soft goods, sharp items, and instruments before the surgery begins. These baseline counts provide the exact numbers you will use to verify that everything is accounted for before the surgeon closes the incision. Performing precise and consistent surgical counts is a non-negotiable standard of perioperative nursing. If the surgical team adds new sponges or instruments to the sterile field during the procedure, those items must be immediately added to your count record. Before the surgeon begins to stitch the final surgical cavity closed, you will initiate the closing count to ensure no item has been left behind. If a count is ever incorrect, the entire surgical team must stop and thoroughly search the surgical field, the floor, and the trash bins until the missing item is found. If the item remains missing, an X-ray is usually required to confirm it is not inside the patient. Medication safety on the sterile field is another major intraoperative priority tested on the certification exam. Whenever you pass a medication to the sterile surgical technologist, you must read the medication label aloud, including the drug name, strength, and expiration date. The technologist must then clearly label the syringe or cup on the sterile field immediately. Unlabeled medications on the sterile field are incredibly dangerous and must be discarded immediately because you can never guarantee what they are. Keeping the patient warm during surgery, known as maintaining normothermia, is a critical safety intervention you will manage. Operating rooms are kept very cold, and anesthesia disrupts the body's natural ability to regulate its own temperature. If a patient gets too cold, they face a higher risk of surgical site infections, increased bleeding, and a longer recovery time. You will use forced air warming blankets, warm intravenous fluids, and warm surgical irrigation to actively protect the patient's core body temperature. You will frequently manage the safety of the electrosurgical unit, which uses electrical current to cut tissue and stop bleeding. To use this safely, you must place a sticky dispersive pad, often called a grounding pad, on the patient's skin. This pad safely pulls the electrical current out of the patient's body and returns it to the machine, preventing severe electrical burns. You must always place this pad on clean, dry skin over a large muscle mass, and never over a bony prominence or a metal implant. Pneumatic tourniquets are often used during limb surgeries to temporarily stop blood flow and give the surgeon a clear, bloodless view. However, leaving a tourniquet inflated for too long can cause permanent tissue death and nerve damage. The perioperative nurse is responsible for documenting the exact time the tourniquet is inflated and loudly warning the surgeon when the inflation time reaches standard safety limits, usually around 90 minutes to 2 hours. This precise timekeeping is a direct patient advocacy role you will perform daily. Throughout the entire surgery, you act as the circulating nurse, constantly scanning the room for breaks in sterile technique and monitoring the patient's overall environment. You are the communication link between the sterile team, the anesthesia provider, and the patient's family waiting outside. Your constant vigilance ensures that the surgical environment remains a highly controlled and safe space. Understanding this overarching responsibility of continuous assessment is key to passing the certification exam. Congratulations for completing this second section on intraoperative patient safety and positioning. I strongly encourage you to complete the attached practice test right now to check your understanding of these critical rules. Answering practice questions greatly improves your retention and exam readiness by helping you practice recalling specific safety protocols. The practice test is included with this lesson, so dive in and embrace active learning. We will naturally transition into protecting the sterile environment next, so keep up your momentum and I will see you in Section 3. Welcome to Section 3 of the CNOR exam preparation course, where we will focus on infection prevention, control, and sterilization. In this lesson, you will learn the vital practices that protect both patients and healthcare workers from dangerous surgical site infections. Understanding these principles is incredibly important because maintaining a sterile environment is the absolute foundation of a successful surgical outcome. Get ready to explore the fascinating life cycle of surgical instruments and the strict rules of asepsis that keep our operating rooms safe. Let us jump right in and continue your journey toward becoming a certified perioperative nurse. Asepsis is the foundational concept of infection control in the operating room, and it simply means the absence of disease-causing microorganisms. We practice two types of asepsis, which are medical asepsis and surgical asepsis. Medical asepsis involves basic clean techniques, like routine hand-washing and wiping down surfaces, to reduce the number of germs. Surgical asepsis, which we use inside the operating room, goes much further by completely eliminating all microorganisms from objects and areas to create a truly sterile environment. It is critical to understand the difference between something being clean and something being sterile. Clean means an item has been heavily washed and disinfected, making it safe to touch with bare hands, but some hardy spores might still survive. Sterile means an item has undergone a rigorous process, like steam under pressure, that kills absolutely every living microorganism, including those tough bacterial spores. On the exam, you must remember that only completely sterile items can be introduced into the sterile surgical field. Before you can even enter the restricted area of the operating room, you must be wearing the proper surgical attire. This includes freshly laundered surgical scrubs provided by the hospital, a head covering that completely hides all of your hair, and dedicated shoes or shoe covers. You must also remove all jewelry, including rings and watches, because rings harbor dangerous bacteria that regular handwashing cannot remove. Proper attire is your first personal defense against shedding your own skin cells and bacteria into the surgical environment. Once you are properly dressed, sterile team members must perform a surgical hand antisepsis, commonly known as a surgical scrub, before putting on their sterile gown and gloves. The goal of the surgical scrub is to remove dirt, skin oils, and transient microbes from the hands and forearms, while also reducing the resident bacteria that naturally live deep in your skin. You will use a specialized antimicrobial soap or an alcohol-based surgical hand rub, following a strict timed method or a counted stroke method. This process leaves an antimicrobial residue that continues to kill bacteria under your sterile gloves for hours. After completing the surgical scrub, The team member enters the operating room with their hands held high to prevent contaminated water from dripping down to their clean fingertips. They will then dry their hands with a sterile towel and slide into a sterile surgical gown. It is crucial to know that the surgical gown is only considered sterile in the front, from the chest down to the level of the sterile field, and from the fingertips to 2 inches above the elbows. The back of the gown is never considered sterile, which is why sterile team members must never turn their backs to the sterile table. The sterile field is the designated area immediately around the patient where only sterile items are allowed. The surgical technologist and circulating nurse work together to carefully open sterile instrument trays and sterile drapes to build this highly controlled zone. A major rule you must remember for the exam is that the edges of any sterile drape or sterile package wrapper are considered unsterile. You must maintain a 1-inch safety margin around the edges to prevent accidental contamination. Before the surgeon makes an incision, the patient's skin must be meticulously cleaned with a powerful antiseptic solution, a process known as surgical skin prepping. The goal here is not to sterilize the skin, because human skin can never be completely sterilized without destroying the tissue. Instead, the goal is to significantly reduce the microbial count on the skin to prevent those bacteria from entering the surgical wound. The most common prepping solutions contain alcohol, chlorhexidine, or iodine, and you must check the patient's allergies carefully before selecting a product. The physical technique used to apply the skin prep is highly specific and frequently tested. You must start at the exact site of the planned incision and clean in expanding circular motions moving outward toward the periphery. You must never bring a soiled prep sponge back over an area you have already cleaned, because this will drag bacteria right back to the incision site. This clean to dirty concept is a golden rule in perioperative nursing that applies to prepping, wound care, and general cleaning. After the skin prep solution has fully dried, the surgical team places sterile surgical drapes over the patient, leaving only the freshly prepped incision site exposed. Waiting for the prep to dry completely is a massive safety requirement, especially when using alcohol-based solutions, because wet alcohol vapors can easily catch fire when the surgeon uses electrical surgical tools. Once a sterile drape is placed on the patient, it must never be shifted or moved, because moving the drape can pull bacteria from an unsterile area directly into the sterile field. Keeping the operating room environment clean between surgeries is another massive component of infection prevention. After a surgery finishes and the patient leaves the room, the environmental services team and nursing staff perform a room turnover cleaning. This involves wiping down the surgical bed, the overhead lights, and any equipment used during the case with hospital-grade chemical disinfectants. This rapid but thorough cleaning stops the cross-contamination of bacteria between the previous patient and the next patient. Now let us look at the life cycle of surgical instruments, starting with the decontamination process. After surgery, all used dirty instruments are transported out of the operating room to the sterile processing department in a leak-proof, closed container to protect the hospital hallways from contamination. Once in the decontamination area, staff wearing heavy-duty protective equipment manually clean the instruments with specialized enzymatic detergents to remove all visible blood, tissue, and bone fragments. Instruments must be completely visually clean before they can be effectively sterilized. After the instruments are thoroughly washed and dried, they move into the clean assembly area of the sterile processing department. Here, skilled technicians inspect every single instrument under magnifying lights to ensure they are perfectly clean and functioning correctly, checking for dull scissors or stiff hinges. The instruments are then organized into specific trays, wrapped in special protective surgical wrappers, and securely taped shut with chemical indicator tape. This packaging protects the instruments from the outside environment after they come out of the sterilizer. The most common and reliable method of sterilizing surgical instruments is steam sterilization, often called autoclaving. Steam sterilization uses high pressure to force incredibly hot steam deep into the instrument trays, destroying all microbial life, including those highly resistant bacterial spores. For the exam, you need to know that steam sterilization requires 4 precise parameters to be successful, which are the right amount of steam, the correct high pressure, a specific high temperature, and a required amount of time. If any of those 4 factors fail, the instruments are not considered sterile. Not all surgical items can withstand the extreme heat and moisture of a steam sterilizer, especially delicate cameras and flexible plastic tubing. For these heat-sensitive items, we use alternative low-temperature methods like ethylene oxide gas or hydrogen peroxide gas plasma sterilization. These chemical methods are highly effective at killing microbes without melting plastic or damaging fragile lenses. However, ethylene oxide gas takes a very long time to work and requires a lengthy aeration period to remove toxic fumes before the items are safe for human contact. To guarantee that the sterilization equipment is actually working correctly, we use 3 distinct types of monitoring systems. The first type is physical monitoring, which involves checking the digital printouts and gauges on the sterilizer machine itself. The operator must verify that the machine reached the correct temperature, pressure, and time during the cycle before they even open the door. Physical monitoring provides immediate mechanical proof that the cycle ran exactly as programmed. The second monitoring method uses chemical indicators, which are special pieces of paper or tape placed inside and outside of every single instrument package. These indicators contain heat-sensitive chemicals that change color when they are exposed to specific sterilization conditions, like a specific temperature for a certain amount of time. Before you place any instrument on your sterile field, you must visually check the chemical indicator inside the tray to ensure it changed to the correct passing color. The third and most critical method of monitoring is the biological indicator. A biological indicator is a tiny vial containing millions of highly resistant, live bacterial spores that is placed inside the sterilizer alongside the instrument trays. After the cycle finishes, this vial is sent to the lab and incubated to see if any spores survived. If the extreme sterilization process successfully killed these super tough test spores, we can confidently assume all other typical bacteria on the instruments were also destroyed. Finally, infection control requires strict management of who and what enters the operating room environment. Operating room suites are divided into unrestricted, semi-restricted, and restricted zones, each with its own specific clothing and traffic rules. Keeping the operating room doors closed as much as possible is a major rule you will be tested on, because opening the door disrupts the specialized positive pressure air ventilation system that pushes clean air down over the patient and keeps dirty hallway air out. Congratulations on completing this third section covering infection prevention, control, and sterilization. I highly encourage you to complete the attached practice test right now to reinforce these complex sterilization concepts while they are fresh in your memory. Practice questions greatly improve your retention and exam readiness by helping you practice recalling specific infection control protocols. The practice test is included with this lesson, so please take advantage of it to support your active learning journey. Next, we will explore surgical instrumentation, equipment, and anesthesia, so keep up the excellent work and I will see you in the next section. Welcome to Section 4 of the CNOR exam preparation course, where we will explore surgical instrumentation, equipment, and anesthesia. In this lesson, you will learn about the complex tools used during surgery and how we keep patients safe while they are under anesthesia. Understanding this equipment is incredibly important because the perioperative nurse is responsible for managing these devices and supporting the anesthesia provider. Get ready to uncover the technology that makes modern surgery possible and build the knowledge you need to ace these exam questions. Let us jump right in and start exploring. Let us start by categorizing surgical instruments, beginning with cutting and dissecting tools. These instruments have incredibly sharp edges and are used to cut through tissue or separate different anatomical structures. The most common examples are scalpels, which use disposable blades, and surgical scissors, like Mayo or Metzenbaum scissors. On the exam, you must remember that these sharp items require careful handling to prevent accidental cuts to the patient or the surgical team. The next category is grasping and holding instruments. These tools are designed to securely hold tissue, blood vessels, or even other instruments without causing unnecessary damage. Forceps, which look like large tweezers, are a classic example of a grasping tool used to hold skin edges together while the surgeon places stitches. Recognizing the difference between delicate forceps used for soft tissue and heavy-toothed forceps used for tough muscle will help you answer situational exam questions accurately. Clamping and occluding instruments form our third major category. Surgeons use these tools, commonly called hemostats, to clamp blood vessels closed and stop bleeding during a procedure. They have interlocking teeth near the handle that allow them to click shut and hold tightly onto a bleeding vessel. Managing bleeding is a critical part of any surgery, so understanding how these clamps work is essential for anticipating the surgeon's needs. Retracting and viewing instruments are used to pull back skin, muscle, or organs to give the surgeon a clear view of the surgical site. Some retractors are handheld, meaning a surgical assistant must physically hold them open for the entire surgery. Other retractors are self-retaining, meaning they have a mechanical lock that holds them open automatically, reducing hand fatigue for the surgical team. Ensuring retractors do not put too much pressure on delicate tissues is a key safety observation. Safe passing of these instruments, especially sharp ones, is a heavily tested safety protocol. To prevent dangerous needle sticks and cuts, the surgical team uses a neutral zone strategy. The neutral zone is a designated spot on the sterile field, like a small plastic basin, where sharp items are placed by one person and then picked up by another. This eliminates the risk of hand-to-hand passing, ensuring that two people never touch a sharp scalpel at the exact same time. Moving into operating room equipment, you will frequently work with the electrosurgical unit, or ESU. This machine uses electrical current to quickly cut through tissue and burn tiny blood vessels to stop bleeding. The ESU comes in two forms, which are monopolar and bipolar. Monopolar uses a single active pen and requires a grounding pad on the patient, while bipolar passes current strictly between the two tips of a specialized forceps, requiring no grounding pad at all. Using the electrosurgical unit creates a dangerous byproduct known as surgical smoke plume. When tissue is burned, it releases a toxic smoke that contains dangerous chemicals, carbon particles, and even living viral fragments. Breathing in this smoke is highly hazardous to the surgical team and the patient. You must always use a specialized smoke evacuation system, which acts like a powerful vacuum attached to the surgical pen, to pull this toxic smoke safely out of the room. Lasers are another powerful tool you must manage carefully in the operating room. Surgical lasers use intense beams of light to cut or vaporize tissue with extreme precision. The most critical safety measure when using a laser is protecting everyone's eyes, including the patient. Every person in the room must wear specific safety glasses that match the exact wavelength of the laser being used, and the patient must have their eyes covered with protective wet eye pads. Radiation safety is a frequent exam topic because X-rays and fluoroscopy machines are heavily used to visualize bones and implants during surgery. Radiation exposure is cumulative, meaning the damage adds up in your body over your entire lifetime. You protect yourself using three principles, which are minimizing your time near the radiation, maximizing your distance from the machine, and using lead aprons for heavy shielding. Stepping out of the room or standing far back is the best way to protect your thyroid and vital organs. Pneumatic tourniquets are powerful cuffs placed around a patient's arm or leg to temporarily stop blood flow. Before the cuff is inflated, the surgeon will tightly wrap the limb with an elastic rubber bandage, called an S-March bandage, to squeeze all the blood out of the arm or leg. This process is called exsanguination, and it creates a completely bloodless surgical view. You must carefully check the patient's skin under the tourniquet cuff before and after surgery to ensure no serious blistering has occurred. Now we transition to your critical role in supporting the anesthesia provider. Before a patient goes to sleep, you will help place basic monitoring equipment, like blood pressure cuffs and oxygen sensors, on the patient. During the induction of general anesthesia, which is when the patient actually goes to sleep, you must remain right next to the patient to provide physical and emotional support. You must never leave the room during induction because this is the most dangerous time for the patient's airway to collapse. General anesthesia involves administering intravenous drugs and inhaled gases to create a state of total unconsciousness and muscle relaxation. Because the patient's breathing muscles stop working under general anesthesia, the provider must insert a breathing tube down the patient's windpipe, known as an endotracheal tube. You must anticipate the need for a mechanical ventilator and have emergency suction equipment turned on and immediately ready to clear any unexpected secretions from the throat. Regional anesthesia is a different approach where only a specific region of the body is numbed, like the lower half of the body during a cesarean section. This includes spinal and epidural blocks, where numbing medication is injected directly into the back near the spinal cord. A major complication of regional anesthesia that you will be tested on is a sudden, severe drop in the patient's blood pressure. You must monitor their vital signs constantly and have intravenous fluids ready to treat these dangerous blood pressure drops. Monitored anesthesia care, often called MAC, involves giving the patient relaxing intravenous sedatives and pain medication while they remain breathing on their own. The patient is usually sleepy but can still follow simple commands. Even though MAC seems less risky than general anesthesia, the patient can easily slip into a deeper state of sedation and stop breathing. You must monitor their oxygen levels just as closely as you would during a major general anesthetic procedure. Malignant hypothermia is a rare but deadly genetic reaction to specific general anesthesia gases and a muscle relaxant called succinylcholine. If a susceptible patient receives these drugs, their metabolism skyrockets, causing an extreme rise in body temperature, rigid muscles, and heart failure. As a perioperative nurse, you must recognize the first signs, like a sudden spike in carbon dioxide levels, and immediately call for the emergency malignant hypothermia cart. If malignant hypothermia triggers, the entire surgical team must act instantly. You will stop the triggering gases, hyperventilate the patient with pure oxygen, and aggressively cool their body with ice packs and cold intravenous fluids. The absolute most important fact for the exam is knowing the specific antidote for this crisis, which is a medication called dantrolene. Mixing and pushing large doses of dantrolene as fast as possible is the only way to reverse this life-threatening reaction. Understanding reversal agents is another common pharmacology topic on the certification exam. Reversal agents are medications given to instantly block the effects of sedatives or narcotics if a patient receives too much. You need to memorize that naloxone, commonly known as Narcan, reverses opioid pain medications. You also need to know that flumazenil is the specific reversal agent used for benzodiazepine sedatives, helping a patient wake up quickly in an emergency. To ensure the breathing tube is properly placed in the patient's windpipe and not in their stomach, the anesthesia team uses a monitor called a capnograph. Capnography measures the exact amount of carbon dioxide the patient breathes out with every single breath. Seeing a strong, steady carbon dioxide waveform on the monitor is the absolute gold standard for confirming that oxygen is safely reaching the patient's lungs. This is a critical monitoring concept that frequently appears on the CNOR exam. Congratulations on successfully finishing Section 4 of our course. You have absorbed a huge amount of information regarding instruments, equipment, and anesthesia. I highly encourage you to complete the attached practice test right now to solidify your understanding of these critical safety rules. Practice questions are the best way to improve your exam readiness and lock this information into your long-term memory. The practice test is included with this lesson, so please dive in and keep learning actively. Next, we will cover postoperative care and documentation, so keep up your amazing effort and I will see you in Section 5. Welcome to Section 5 of the CNOR exam preparation course where we explore postoperative care, communication, and documentation. In this lesson, you will learn how to safely transition the patient from the operating room to the recovery area and accurately record their surgical journey. Understanding this phase is incredibly important because how we hand over care and document our actions directly impacts patient safety and protects you legally. Get ready to master the essential communication tools and charting standards that are heavily tested on the certification exam. Let us jump right in and continue building your perioperative knowledge. The postoperative phase begins the moment the surgical dressing is applied and the patient is transferred out of the operating room. Your immediate priority is safely moving the patient to the post-anesthesia care unit, commonly known as the PACU. During this physical transfer, the patient is highly vulnerable to changes in blood pressure and airway blockages, especially as the anesthesia begins to wear off. The anesthesia provider manages the airway at the head of the bed while you monitor the surgical site and ensure all intravenous lines and drainage tubes remain secure. Once you arrive in the recovery room, you must perform a comprehensive transfer of care to the receiving PACU nurse. This handoff is a critical safety checkpoint, and you must use a standardized communication tool like SBAR to ensure no vital details are missed. SBAR stands for Situation, Background, Assessment, and Recommendation, and it provides a clear, structured way to relay complex medical information quickly. The CNOR exam emphasizes standardized communication because chaotic or incomplete handoffs are a major cause of medical errors and patient harm. The first step of your handoff is the situation, where you introduce the patient by name and state the exact surgical procedure that was just completed. You will also mention the name of the primary surgeon and the type of anesthesia the patient received, whether it was general, regional, or local. This gives the receiving nurse an immediate, clear understanding of what the patient just went through. Starting with a concise situation statement sets a professional tone and focuses everyone's attention on the patient's current status. Next, you provide the background, which includes the patient's relevant medical history, allergies, and preoperative baseline vital signs. You must highlight any chronic conditions, such as diabetes or heart disease, that could complicate their immediate recovery process. If the patient has a severe latex allergy or requires a language interpreter, this is the exact moment to reinforce that information. The background context helps the PACU nurse anticipate potential complications before they become life-threatening emergencies. The assessment portion of the handoff is where you detail everything that happened during the actual surgery. You will report the estimated blood loss, the total amount of intravenous fluids or blood products given, and the status of the surgical dressing. It is also crucial to mention if any surgical drains or urinary catheters were placed, and exactly how much output they have collected so far. This real-time assessment data gives the recovery nurse a precise baseline to measure the patient's postoperative progress against. Finally, you provide your recommendations for the patient's ongoing care in the recovery unit. This includes sharing the surgeon's specific postoperative orders, such as target blood pressure parameters or requested lab tests. You will also recommend when the patient should receive their next dose of pain medication or antibiotics based on what was administered during surgery. Ending with clear recommendations ensures a seamless continuation of care and leaves the PACU nurse with a solid action plan. While you are handing off care to the PACU nurse, the surgeon is typically updating the patient's family in the waiting room. However, you also have a major responsibility regarding family communication and support. If a surgery takes significantly longer than expected, you should designate someone to provide brief, non-medical updates to the anxious family members. Keeping the family informed reduces their stress and demonstrates the high level of compassionate care expected of a certified perioperative nurse. During all of these communications, you must strictly protect the patient's privacy and confidentiality under federal HIPAA regulations. You must never discuss a patient's surgical details in public areas like hallways, elevators, or the hospital cafeteria where unauthorized people might overhear. Even when speaking with family members, you must verify that the patient actually gave permission for those specific individuals to receive their medical information. The exam will heavily test your ability to balance clear communication with strict legal privacy boundaries. Now let us transition to the critical legal concept of perioperative documentation. The patient's medical record is a legal document that tells the entire chronological story of their surgical experience. The golden rule of nursing documentation that you must memorize for the exam is that if it was not documented, it legally was not done. Your charting must be accurate, objective, and timely, because it serves as the official proof that you provided safe, high-quality care. When writing your nursing notes, you must always use objective language rather than subjective opinions. Objective language means charting exactly what you saw, heard, or measured, such as stating the patient's skin is red and warm to the touch. You should avoid subjective statements like writing that the patient seems angry or the wound looks bad, because these are personal interpretations that cannot be proven. Clear, factual documentation protects both the patient's medical history and your professional nursing license. Many modern electronic health records use a system called charting by exception to save time and reduce duplicate data entry. Charting by exception means you only document detailed narrative notes when a patient's assessment falls outside of the normal, predefined hospital standards. For example, if the patient's skin is perfectly intact, you simply click a box stating normal, but if you find a new bruise, you must write a detailed note describing it. You must understand this concept because it dictates how you interact with most electronic surgical flowsheets. One of the most important things you will document is the patient's surgical position and exactly what padding you used to protect them. You must record the names of the team members who helped position the patient, the specific devices used, and the placement of any safety straps. You also need to document the condition of the patient's skin before they were positioned and immediately after they were moved back onto the stretcher. This detailed record is your primary defense if a patient later claims they suffered a positioning injury during surgery. Documenting surgical implants. Documenting surgical implants, such as a titanium knee joint, a pacemaker, or even surgical mesh, requires extreme. Documenting surgical implants, such as a titanium knee joint, a pacemaker, or even surgical mesh, requires extreme precision. For every implant placed inside the patient, you must record the manufacturer, the exact serial number, the lot number, and the expiration date. This information is legally required so the hospital can instantly track and notify patients if a manufacturer ever issues a medical device recall. Missing a single digit on an implant record is a major safety violation that the certification exam will certainly ask about. Surgical specimens, which are pieces of tissue removed for laboratory testing, also require meticulous documentation and chain of custody tracking. You must verbally verify the name of the specimen with the surgeon before you label the specimen cup. The label must include the patient's name, the exact anatomical source of the tissue, and the date and time of collection. If a breast biopsy is mislabeled as coming from the right side instead of the left, it can lead to devastating and unnecessary surgical treatments for the patient. As we discussed earlier, you will dispense medications to the sterile field, and every single drop must be documented. You must chart the name of the drug, the dosage, the route of administration, and the exact time it was passed to the surgical technologist. Additionally, at the end of the surgery, you must document how much of that medication the surgeon actually used and how much was wasted. Accurate medication charting is legally required to prevent drug diversion and ensure the patient's total anesthesia dosages are correct. The surgical timeout is the ultimate safety pause, and your documentation must prove that it happened perfectly. You must chart the exact time the timeout occurred, who initiated it, and that every single team member actively participated and agreed. You must verify that the patient's identity, the procedure, the site, and the display of necessary X-rays were all confirmed out loud. An auditor reading your chart should clearly see that the universal protocol was followed without any exceptions. Knowing how to properly correct a documentation error is a frequently tested legal concept. If you make a mistake in a paper chart, you must never use correction fluid or scribble out the word so it cannot be read. Instead, you must draw a single line through the incorrect entry, write the word error, and initial and date the correction. In an electronic health record, you must use the system's official addendum feature to correct the mistake, leaving a clear digital footprint of what was changed and why. The final step of the perioperative nursing process is evaluating the patient's outcomes against the goals you set during the preoperative phase. You must document whether the patient met their expected goals, such as maintaining skin integrity and remaining free from surgical site infections. If a goal was not met, you must clearly chart the exact complication that occurred and what interventions were taken to treat it. Evaluating outcomes completes the cycle of care and provides valuable data to improve future nursing practices. Congratulations on completing Section 5 and mastering the critical principles of postoperative care, communication, and documentation. I strongly encourage you to complete the attached practice test right now so you can apply these legal and communication concepts immediately. Answering practice questions greatly improves your retention and ensures you are totally prepared for the exam. The practice test is included with this lesson, so keep up the active learning and test your knowledge. Next, we will tackle our final topic of professional accountability and ethics, so keep up the fantastic work and I will see you in Section 6. Welcome to Section 6, the final module of our CNOR exam preparation course, where we tackle professional accountability, ethics, and emergency situations. In this lesson, you will learn how to navigate the complex legal and moral responsibilities of a perioperative nurse, alongside mastering the immediate responses required for life-threatening surgical emergencies. Understanding these concepts is critically important because your ability to make ethical decisions and react swiftly during a crisis can literally mean the difference between life and death. Get ready to solidify your role as a true patient advocate and build the ultimate confidence you need for the certification exam. Let us finish strong and dive into our final essential topics. At the core of perioperative nursing is the concept of patient advocacy, which means protecting the rights, health, and safety of the patient who cannot speak for themselves. Because surgical patients are often unconscious or sedated, they are entirely dependent on you to protect them from harm and ensure their wishes are respected. If you see a break in sterile technique or notice a safety hazard, you must speak up immediately, regardless of who made the mistake. The certification exam will test your courage and professional duty to always prioritize the patient above workplace politics or fear of upsetting a surgeon. Ethical dilemmas occur frequently in the operating room, and you must use established ethical principles to guide your actions. One foundational principle is autonomy, which is the patient's right to make their own independent medical decisions, even if you disagree with them. For example, if a competent adult patient refuses a life-saving blood transfusion due to religious beliefs, you must ethically and legally respect that decision. Understanding these core principles helps you navigate difficult situations where the right path is not always clearly defined. Advance directives and do not resuscitate orders, commonly called DNRs, require special attention when a patient enters the surgical environment. Historically, DNR orders were automatically suspended during surgery, but modern ethical standards dictate that this automatic suspension is a violation of patient rights. Today, the anesthesia provider and surgeon must have a specific conversation with the patient before surgery to determine if the DNR should be maintained, fully suspended, or modified during the procedure. You must be completely aware of the patient's exact resuscitation status before the surgery begins. Your professional practice is legally governed by your State Board of Nursing, which defines your legal scope of practice. The scope of practice outlines exactly what tasks, duties, and decisions you are legally authorized to perform based on your education and license. You must never perform a surgical skill or administer a medication that falls outside of this defined scope, even if a physician directly orders you to do it. On the exam, remember that you are always personally accountable for your own actions, regardless of who gave the command. The concepts of negligence and malpractice are highly tested legal topics that you must thoroughly understand. Negligence is a general term meaning a failure to act as a reasonably prudent person would in a similar situation, like leaving a puddle of water on the floor that causes a fall. Malpractice is a specific type of professional negligence where a licensed healthcare worker fails to follow the standard of care, directly resulting in patient injury. To protect yourself from malpractice, you must strictly follow hospital policies, national guidelines, and maintain meticulous documentation at all times. Delegation is another major responsibility that carries significant legal weight in the operating room. You will frequently delegate tasks to unlicensed assistive personnel, such as asking an orderly to help transport a patient or gather positioning equipment. However, you can only delegate basic tasks, and you must never delegate anything that requires nursing judgment, complex assessment, or clinical decision-making. The golden rule of delegation is that while you can assign a task to someone else, you fully retain the ultimate accountability for the outcome of that task. Fostering a just culture is essential for promoting safety and continuous quality improvement in the surgical environment. A just culture is a workplace environment where staff members are highly encouraged to report errors and near misses without the fear of automatic punishment. Instead of blaming individuals for honest mistakes, the hospital focuses on identifying the underlying system failures, like confusing medication labels, that led to the error. You should expect exam questions that emphasize reporting errors as a positive, necessary step for improving overall patient safety. To continuously improve patient care, perioperative nurses must rely heavily on evidence-based practice. Evidence-based practice involves using the most current, high-quality research studies to make clinical decisions, rather than just doing things the way they have always been done. When national organizations update their guidelines regarding skin prepping or sterilization, it is because new scientific evidence has proven a safer or more effective method. Staying updated with these changing guidelines is a hallmark of professional accountability. Now we will transition into handling intraoperative emergencies, starting with the critical danger of surgical fires. The operating room is a high-risk environment for fires because it constantly contains all three elements of the fire triangle, which are an ignition source, a fuel, and an oxidizer. Ignition sources include lasers and electrosurgical pens, fuels include alcohol-based skin preps and surgical drapes, and the oxidizer is the oxygen flowing from the anesthesia machine. You must actively manage these three elements, such as ensuring alcohol preps are completely dry, to prevent a devastating fire. If a fire does ignite on or inside the patient, the surgical team must instantly follow a coordinated emergency response. Your very first action is to immediately remove the burning materials, like the surgical drapes, from the patient and extinguish them on the floor. Simultaneously, the anesthesia provider will stop the flow of oxygen and any flammable anesthetic gases to remove the oxidizer. The exam will test your rapid response priorities, emphasizing that stopping the fire and protecting the patient's airway are your absolute first steps. For larger fires that threaten the room, you will use the classic RACE acronym, which stands for Rescue, Alarm, Confine, and Extinguish. You first rescue the patient and anyone in immediate danger, then pull the fire alarm to alert the hospital. Next, you confine the fire by closing all operating room doors to stop the smoke from spreading into the hallways. Finally, if the fire is small and manageable, you use the correct fire extinguisher to put it out, prioritizing your own safety so you can continue helping the patient. Cardiac arrest during surgery is a terrifying emergency that requires flawless teamwork and immediate basic life support. If a patient's heart stops, the surgeon will immediately begin chest compressions while the anesthesia provider manages the breathing tube and pushes emergency medications. As the circulating nurse, your primary role is to rapidly call for the emergency crash cart, bring the defibrillator to the sterile field, and meticulously document the exact timing of every medication given. Your calm coordination keeps the resuscitation effort organized and efficient. Massive hemorrhage is another life-threatening crisis where the patient loses a dangerous amount of blood very quickly. When this occurs, the team will activate the massive transfusion protocol, which is a hospital-wide system designed to deliver large amounts of blood products to the operating room instantly. You will be responsible for rapidly checking the blood types with another nurse and operating specialized rapid infuser machines that warm and pump the blood into the patient. Acting with incredible speed is necessary to prevent the patient from going into irreversible hypovolemic shock. You must also be prepared to recognize and respond to severe allergic reactions known as anaphylaxis. In the operating room, anaphylaxis is most commonly triggered by latex, intravenous antibiotics, or muscle relaxant medications. The first signs are often a sudden, drastic drop in blood pressure and an inability to push air into the lungs due to severe airway swelling. The primary, life-saving treatment for anaphylaxis is the immediate administration of epinephrine, which you must be ready to quickly grab from the emergency cart. Local anesthetic systemic toxicity, often abbreviated as LAST, is a rare but dangerous emergency that happens when numbing medication accidentally enters the patient's bloodstream. This can occur during regional nerve blocks or large local injections. Early warning signs include ringing in the ears, a metallic taste in the mouth, and sudden confusion, which can rapidly progress to severe seizures and cardiac arrest. You must know that the specific rescue treatment for this toxicity is the rapid intravenous administration of a specialized lipid emulsion therapy. Power failures are a unique environmental emergency that you must know how to handle to maintain continuous patient safety. If the main hospital power goes out, the emergency backup generators should activate within seconds. However, you must know exactly which electrical outlets in your operating room are connected to generator power, which are almost universally colored red. In a blackout, you must immediately ensure that all life support equipment, like the anesthesia ventilator and the cardiopulmonary bypass machine, are plugged directly into those red emergency outlets. As we wrap up these emergency concepts, remember that your professional development does not end when you pass the certification exam. Maintaining your CNOR credential requires a lifelong commitment to continuing education and staying current with the latest surgical advancements. Joining professional organizations, reading clinical journals, and attending surgical conferences are excellent ways to continually build your expertise. Professional growth ensures you remain a highly competent, confident, and reliable leader in the perioperative environment. Reflecting on your daily practice and seeking out leadership opportunities are also key components of professional accountability. Whether you serve as a preceptor for new nurses, participate in hospital policy committees, or simply advocate for better safety equipment, your voice matters deeply. You are the final line of defense for the vulnerable surgical patient, and embracing that immense responsibility is what makes perioperative nursing such a rewarding and respected specialty. You now have the comprehensive knowledge needed to excel. Congratulations for completing this sixth and final section of our course. I highly encourage you to complete the attached practice test right now to cement your understanding of these critical legal, ethical, and emergency concepts. Practice questions are the absolute best way to improve your retention and guarantee your ultimate exam readiness. The final practice test is included with this lesson, so please utilize it to maximize your active learning. You are now fully prepared to transition into your final comprehensive exam review, so walk into that testing center with confidence and finish your certification journey positively and professionally.